A 52-year-old male in the intensive care unit recently had a left subclavian central venous catheter placed. Shortly after flushing the line, the patient complained of sudden retrosternal chest pain and became hypotensive. I am showing you the post-insertion chest radiograph and an axial chest computed tomography scan. Describe the findings.
The chest radiograph shows the central venous catheter entering from the left subclavian vein. However, instead of coursing vertically down the superior vena cava, the catheter takes an unusual medial path, crossing the midline at the level of the aortic arch. There is also moderate widening of the superior mediastinum and a left apical pleural cap. The axial chest computed tomography scan confirms that the catheter tip lies outside the superior vena cava, extending into the mediastinal fat. There is a surrounding large, hyperdense fluid collection compressing the adjacent mediastinal structures. These findings indicate vascular perforation by the central venous catheter, resulting in a mediastinal hematoma.
What is the most common complication of central venous catheter placement? And what are the two most serious complications of advancing a catheter tip too far into the right atrium?
The most common complication of central venous catheter placement is malposition, which can occur in up to 40% of cases. If a catheter is advanced too far and enters the right atrium, the two most serious complications are cardiac arrhythmias, due to mechanical irritation of the conduction system, and cardiac perforation, which can lead to life-threatening cardiac tamponade.
What is the optimal position for a central venous catheter tip, and how should this vascular perforation be managed?
The optimal location for the catheter tip is the superior vena cava, ideally at the cavotrial junction. The catheter should run parallel to the vessel wall and not abut it. In terms of management, all infusions through this line must be stopped immediately. We should not withdraw the catheter blindly, as the line itself may be tamponading the venous puncture site. I would immediately consult interventional radiology and vascular surgery to evaluate for controlled withdrawal under fluoroscopic guidance, and perform a contrast-enhanced computed tomography angiogram to rule out active bleeding. If the patient develops signs of cardiac tamponade, an emergency pericardiocentesis is required. I would notify the clinical team immediately.